you tell a cardiologist that his patient has severe mitral regurgitation, he wants to know two things about it. One, the etiology of mitral regurgitation, and two, the best way to manage it. Does the patient only need follow-up for now, or needs medical treatment, for example with ACE inhibitors, or needs surgical intervention? This is how a cardiologist looks at mitral regurgitation and classifies mitral regurgitation. It's an etiological classification. As you can see, mitral regurgitation can be primary, also known as organic, or secondary, also known as functional. Primary or organic mitral regurgitation is due to structural abnormalities of the mitral valve itself, which can be congenital or degenerative. For example, Barlow's disease, fibroelastic deficiency, and mitral valve involvement in Marfan's syndrome and Ehlers-Danlos syndrome. It can be rheumatic, it can be due to infective endocarditis, it can be due to an acute ischemic event leading to ruptured papillary muscle, and very rarely it can be due to trauma. Functional mitral regurgitation is caused by regional or global left ventricular remodeling and dilatation. So this is how a cardiologist looks at mitral regurgitation. When it comes to the cardiac surgeons, they have a whole new set of questions that they want to ask. They want to know the mechanism or functional classification of mitral regurgitation. They want to know if the valve can be repaired or if it needs to be replaced. And if the valve is repairable, they want to know the risk of failure, risk of significant residual mitral regurgitation, and the risk of postoperative SAM and LVOT obstruction. By the way, why the cardiac surgeons are so much interested in mitral valve repair? It's because most of the current evidence show that mitral valve repair has superior clinical outcomes to mitral valve replacement. Several registry studies with thousands of patients in them have shown that operative mortality after mitral valve replacement is 2 to 3 times more than mitral valve repair. However, mitral valve repair is technically more challenging. That's why every cardiac surgeon can do mitral valve replacement, but not every cardiac surgeon can do mitral valve repair. Mitral valve repair needs extra training and subspecialization. And because mitral valve repair can be a challenging and difficult procedure, precise definition of mitral valve morphology is crucial in determining the feasibility, timing, and complexity of the repair. This brings us to Alain Carpentier, the father of mitral valve repair, and his functional classification of mitral regurgitation, which was first introduced in early 1980s. This is an SSFP cine image of the mitral valve at short axis plane of the base of the left ventricle. You can see the mitral valve with its 2 leaflets. This is the anterior leaflet, and this is the posterior leaflet. Carpentier's first contribution was that he looked at the mitral valve and its 2 leaflets and noticed, like many people had noticed before him, that the posterior leaflet had 3 segments, or 3 scalps. Starting from the anterolateral commissure, he called them P1, P2, P3. The anterior leaflet did not have such clear segmentation, such clearly defined segments, but Carpentier called the corresponding areas of the anterior leaflet A1, A2, and A3. So A1 is in front of P1, A2 is in front of P2, and A3 is in front of P3. Now we had the nomenclature to clearly identify, describe, and communicate the anatomical segment or segments involved. This is important because in organic mitral regurgitation, the pathology rarely involves the whole leaflet and is more often either confined to specific segments or much more severe in specific segments. and it's important for the mitral valve surgeon to know where exactly the pathology is. In the next step, Carpentier introduced his functional classification of mitral regurgitation, which is based on the opening and closing motions of the mitral leaflets. There are three types of mitral regurgitation: type 1, type 2, and type 3. In type 1, the leaflet motion is normal. So how can the leaflet motion be normal and we still have mitral regurgitation? There are two possibilities. One is that we have annular dilatation. So although the leaflets are opening and closing normally, there is a gap between them. Because of the annular dilatation, they cannot reach each other. Annular dilatation can be due to cardiomyopathies or even chronic atrial fibrillation, which can lead to dilatation of the left atrium and annular dilatation. Or we can have leaflet perforation, for example, secondary to infective endocarditis. Type 2 is when the leaflet motion is increased, and that's what you see with mitral valve prolapse. So the free edge of the leaflet travels above the plane of the mitral annulus during systole. And type 3 is when the leaflet motion is restricted, and it is subclassified into type 3A and type 3B. In type 3A, the leaflet motion is restricted in both systole and diastole, and this is what you see in rheumatic valve disease. In type 3B, the leaflet motion is restricted only in systole. That is functional mitral regurgitation, which is due to tethering of mitral leaflets in systole by dysfunctional and displaced papillary muscles. This can be due to ischemic cardiomyopathy or dilated cardiomyopathy. These are the questions the mitral valve surgeon wants to answer before planning the operation. He wants us to confirm the severity of mitral regurgitation. He wants to know the number and direction of regurgitant jets. Why is it important to know the number of jets? Because each jet represents a pathology, and if the surgeon knows this before the operation, he will go and hunt for those pathologies during the operation and try to fix them so they won't be missed. The surgeon wants to know the mechanism of mitral regurgitation and the Carpentier's type. He wants to know if the valve can be repaired or it needs to be replaced. Is it suitable for a minimally invasive technique? He wants to know about the consequences of severe mitral regurgitation. Is the left atrium dilated? What is the size of the left ventricle? What is the ejection fraction? What is the right ventricular function? Is there any significant pulmonary hypertension? He also wants to know the risk of failure or unsuccessful operation, which is defined by residual mitral regurgitation and or significant systolic anterior motion of the mitral leaflets and LVOT obstruction postoperatively. And there are other things that the surgeon also wants to know. The viability of myocardium in patients with ischemic heart disease who may also need bypass grafting at the same time, the presence and severity of any tricuspid regurgitation, and the size of the tricuspid annulus. Many surgeons opt to do a restrictive ring annuloplasty for the tricuspid valve at the time of mitral valve repair if the tricuspid annulus is larger than 40 millimeters. We can answer most of these questions with cardiac MRI. Maybe we cannot measure the pulmonary pressure directly with cardiac MRI, but we can look at the size of the pulmonary arteries. If the pulmonary arteries are dilated, this is an indicator of pulmonary hypertension. This is the MRI protocol to assess the mitral valve. First, we use the SSFP cine sequence to take cine images in the 2-chamber, 4-chamber, and LVOT planes and the short axis stack of the ventricles. Then we use the same sequence and do a mitral valve stack. How do we plan for the mitral valve stack? Choose a basal short axis slice where the mitral valve can be seen well. This is a floppy mitral valve due to Barlow's disease. Then Imagine the line of cooptation. Acquire contiguous stack of oblique slices aligned perpendicular to the central part of the line of cooptation. Start from the superior or anterolateral commissure and come down to the inferior or posteromedial commissure. It usually takes 8 to 10 slices to cover the whole mitral valve. The slice thickness should be 5 millimeters and there should be no gap between the slices. And this is what you get. You get modified LVOT views of the mitral valve. Here you can see A1 and P1. So this is A1 and this is P1. And you can see that the P1 is prolapsing. Here you can see A2 and P2. And again you can see there is severe prolapse of the P2. And here you can see A3 and P3. And you can see that A3 and P3, there is some billowing in them, but they don't prolapse as severely as the previous scallops. After taking the mitral valve stack, you do velocity mapping above the aortic valve to calculate the regurgitant volume and regurgitant fraction. And you also do a through plane velocity mapping plus minus flush sequence cine of mitral regurgitation just above the mitral valve in the left atrium. This will show you the mitral regurgitation in the short axis plane and is useful to see how many jets there are and which scallops they originate from. Then, if relevant, for example, if the patient has coronary disease and is being considered for coronary artery bypass surgery, you give gadolinium to do myocardial viability studies. Now we have done the study and it's time to analyze it. How do we assess the severity of mitral regurgitation? The quantitative measure that we have here is the regurgitant volume and the regurgitant fraction. If the regurgitant volume is more than 60 milliliters, the mitral regurgitation is severe. How do we calculate the mitral regurgitant volume? The best and the most reproducible way is to subtract aortic flow from LV stroke volume. This formula can be used even in the presence of aortic regurgitation. Another way to calculate the mitral regurgitant volume is by subtracting the RV stroke volume from the LV stroke volume. This formula can only be used in the absence of significant regurgitation in other valves. To calculate regurgitant fraction, you divide the mitral regurgitant volume by the LV stroke volume and multiply it by 100. There is one study which tried to correlate echo and CMR quantification of mitral regurgitation, and they came up with these numbers for regurgitant fraction, which you can see here. So according to that one study by Gelfand et al., if the regurgitant fraction is less than 15% with cardiac MRI, the mitral regurgitation is mild, and if it's more than 42%, it is severe. It is important for the surgeon to know about the mitral annulus, particularly if the mitral annulus is calcified and if it is dilated. Cardiac MRI is not good in detecting calcium in the heart. Calcium looks black on MRI, and therefore it can get lost among all other gray and black structures in our black and white images. So we will not see mitral annular calcification very well unless it is severely and heavily calcified. As for the mitral annulus diameters, CMR is very good. In the LVOT view, you can measure the anteroposterior diameter of the mitral valve. If this diameter is more than 35 millimeters, or more than 1.3 times larger than the length of the anterior leaflet in diastole, the mitral annulus is dilated. Here you can see how we measure the mitral annulus anteroposterior diameter and the length of the anterior and posterior leaflets in the LVOT view. Severe annular dilatation is when the annular diameter is more than 50 millimeters or 5 centimeters and is a predictor of operation failure. We can do other measurements in the LVOT view too. We can measure the basal septal thickness, the left ventricular enddiastolic diameter, the left ventricular end systolic diameter, the C-sept, and the aortomitral angle. Here you can see how the basal septal bulge thickness is measured. It is measured in enddiastolic. A septal bulge of more than 15 millimeters in thickness is a predictor of SAM and LVOT obstruction postoperatively. You can measure the left ventricular end diastolic diameter from this view too. You can also use the short axis views to measure the left ventricular end diastolic diameter. The importance of the left ventricular end diastolic diameter here is that a severely dilated left ventricle with end diastolic diameter of more than 65 millimeters or 6.5 centimeters indicates severe left ventricular remodeling and is a predictor of unsuccessful repair. You can also measure the left ventricular end systolic diameter in this view or the short axis views, and if it is less than 45 millimeters, it indicates a small left ventricle where the mitral leaflets are too close to the LVOT and is a predictor of postoperative SAM and LVOT obstruction. Another parameter which is important for the mitral valve surgeons is the C-sept. C stands for cooptation point. Cooptation point is the point where the mitral leaflets coapt in systole. And the C-sept is the shortest distance between the cooptation point and the basal septal bulge in mid-systole. A C-sept of less than 2.5 centimeters is a predictor of SAM and LVOT obstruction after mitral valve repair. This is because the mitral valve repair procedure usually includes ring annuloplasty. So the whole mitral valve ring and annulus moves anteriorly towards the LVOT. This increases the risk of SAM and LVOT obstruction. The aortomitral angle is the angle between the mitral annular plane and the aortic annular plane. And you can measure it in systole and diastole. As you can see, it can be measured very well with cardiac MRI. When the aortomitral angle is more than 120 degrees, the risk of SAM and LVOT obstruction would be low. When it's less than 120, the risk increases. If the etiology of mitral regurgitation is prolapse, the surgeon needs to know the location of the prolapse, which scallop, and the extent of the prolapse. We should pay attention to the terminology used here. Billowing is when a part of the mitral leaflet goes above, or you can say behind, the annular plane, but the coaptation point remains below the annular plane. Prolapse is when part of the mitral leaflet and the coaptation point go above the annular plane in the left atrium. A floppy valve is a valve with thickened leaflets due to redundant tissue. The leaflet thickness is 5 millimeters or more in diameter. A flail leaflet is when the free edge of a leaflet is completely reversed in systole and points towards the left atrium, whereas in prolapse, the tip of the leaflet points towards the left ventricle. Here you can see a floppy mitral valve due to Barlow's disease and severe prolapse of the P2 scallop. There is bileaflet billowing with severe prolapse of the P2 scallop. If the mitral regurgitation is functional, the surgeon wants to know mitral annulus diameter. He also wants to know the location and extent of regional and global left ventricular dysfunction. Is there global LV remodeling, or is there regional LV remodeling, likely due to a posterior myocardial infarction? This will usually be associated with restriction of the posterior leaflet motion, mainly in the P3 scallop, and a posteriorly directed jet of mitral regurgitation. It can be quantified by measuring the distance between the papillary muscles, which is not commonly done. The surgeon also wants to know the tenting area, which is the area between the mitral annulus and mitral leaflet bodies in mid-systole, and the coaptation distance. I show you how these parameters can be measured very well with cardiac MRI. Spiracity index is the ratio of the LV short axis diameter to the left ventricular long axis diameter. Reference ranges are available. Compare this left ventricle to the previous left ventricle. This one is much more spherical, and the sphericity index would be higher. Severe LV dilatation and spherical remodeling is an indicator of unsuccessful repair, and that's why it's important for the surgeon to know about it. It also tells us that most of the LV remodeling has become irreversible, and the patient will not gain any prognostic benefit from the mitral valve repair. These patients should be treated with anti-heart failure treatment with ACE inhibitors, beta blockers, and diuretics, plus minus cardiac resynchronization therapy, if indicated, before being considered for surgery. If the patient does not respond to these measures and remains symptomatic and wants to undergo surgery, he should know that the surgery will only improve his symptoms without any prognostic benefit. This is a severely dilated left ventricle with spherical remodeling of its LV shape, and I want to show you how we measure the tenting area and the coaptation distance. This is how the tenting area is measured. The tenting area is the area between the mitral annular plane and the mitral leaflets in mid-systole in the four-chamber view. A tenting area of more than 2.5 square centimeters is a predictor of unsuccessful repairs. A large tenting area means the leaflets are severely pulled down by the papillary muscles, which itself means the left ventricle is severely dilated and remodeled. And if the remodeling continues after the operation, the patient will develop severe mitral regurgitation again. There is good correlation between echo and cardiac MR measurements of the tenting area. This is the same patient whose tenting area has been measured here with cardiac MRI and here on echocardiography in the four-chamber view. Cardiac MRI gives us a number of 4.38 square centimeter, and from echo it is 4.3 square centimeters. So they correlate very well. Here you can see how the coaptation distance is measured. It is the longest distance between the coaptation point and the mitral annular plane. And if this distance is more than 1 centimeter, it predicts unsuccessful surgery and post-operative mitral regurgitation. This is another parameter which is not often used, but I want to show you how nicely it can be measured with cardiac MRI. The posterior leaflet angle, which is the largest angle between the mitral annular plane and the posterior leaflet in mid-systole, is another indicator of LV remodeling and displacement of the papillary muscle. And if it's more than 45 degrees, it predicts unsuccessful operation. So, in summary, these are the predictors of unsuccessful valve repair in primary or organic mitral regurgitation. Large central regurgitant jet, severe annular dilatation, more than 50 millimeters, involvement of 3 or more scallops, especially if anterior leaflet is involved, leaflet calcification or extensive annular calcification, rheumatic valve disease, and lack of valve tissue due to rheumatic fever or infective endocarditis. As you can see, most of them can be assessed with cardiac MRI. These are the predictors of unsuccessful valve repair in functional mitral regurgitation. If you have a central regurgitant jet, if the coaptation distance is more than 1 centimeter, if the systolic tenting area is larger than 2.5 square centimeters, if the posterior leaflet angle is more than 45 degrees, if there are complex jets centrally and posteromedially, which indicate there is more than one pathology, and if the left ventricle is severely dilated with a left ventricular enddiastolic diameter of more than 65 millimeters. And you saw that all of these can be assessed very well with cardiac MRI. And these are the predictors of SAM and LVOT obstructions. A C-sept shorter than 2.5 centimeters, septal bulge thicker than 15 millimeters, a long posterior leaflet. The normal length of a posterior leaflet is 10 to 15 millimeters. If the posterior leaflet is longer than 2 centimeters, it increases the risk of SAM and LVOT obstruction after mitral valve repair. And if the surgeon knows about this in advance, he can cut and shorten the posterior leaflet during the mitral valve repair. If the left ventricle is not dilated and is hyperdynamic with a left ventricular end systolic diameter less than 45 millimeters, or the major risk factor for SAM and LVOT obstruction, if the annuloplasty ring has been done with an undersized ring. I have put it here because it is a major risk factor for developing SAM and LVOT obstruction post-operatively. This is a nice image of the mitral valve in the surgical view. You can see the anterior leaflet here and the posterior leaflet here. There is severe prolapse of the P2 scallop, and you can even see that there is a small ruptured cord attached to the posterior leaflet. Creating 3D images like this is only possible with 3D transesophageal echocardiography at present. You cannot get this from cardiac MR. Everything else, you can.